ونسمع احمد وبعدين ديسكاس مع بعض اللي في حد عنده اسئله، لان احمد هيقدم كيس ستاديز للرانولازين. اتفضل.
Okay. Yeah. Thank you for having me. بصراحة, when I thought of case presentation, I thought actually let's revise in which cases I've written ranolazine actually. So it's not just one case. I'm trying to position what I did, and of course, if anybody has a comment, please. And we've seen this today by Professor Tamer, that not all chronic coronary syndromes are the same. The guidelines for the very first time has did a little bit of a phenotypes according to the patient with heart failure, the patient with typical angina, the patient with the low blood pressure, the post-ACS, the post-intervention, and so on and so. So not all patients are treated the same. It makes sense. It's according to hemodynamics, comorbidities, and such. And kudos to the European Society of Guidelines when they did this in the chronic coronary syndromes. In contrast with heart failure, the European guidelines don't really say which treatment in which patient at what time. They followed it up with a position paper, which is much better. So we should take a look. But what I really liked is this publication provided by Professor Tamer, also by Manolis et al. And it discusses we should look at different problems. It's not just the patient with the left ventricular dysfunction, the post-ACS, the early after intervention. We should take a look on which patients and their comorbidities. And actually, the guidelines stated that we should look at the comorbidities. So let's take a look at a number of patients. This is a nice patient. He's a male. He's 50. Just quickly, I did an intervention to his circumflex, and he has small vessel disease. And we know small vessel disease and ischemia is mainly treated by medical therapy, even in large vessels. And again, the patient is complaining more and more. Full dose beta blockers, full dose nitrates, and the patient is still ongoing with chest pain. So what did I do? Of course, before the data with ranolazine, we used to give nicorandil, we used to up-titrate other calcium antagonists, but actually with the 375, he started to improve a little bit, and with the up-titration to the 500 twice per daily, he did very well. And this is where it goes. In small vessel disease or microvascular angina, you'll find evidence, yes, you can give ranolazine with good outcomes for patients as provided. And we should take care. I remember at the time, Dr. Heba, you don't remember this time, you're younger. Okay, when we used to combine beta blockers and calcium antagonists, I'm not talking about the amlodipine or felodipine. We're talking at a time when we were, giving atenolol and verapamil, diltiazem, which is a total contraindication. So we can give dihydropyridine, we can give with a beta blocker, but actually we have other tools we can use because these combinations may be very hazardous. This is a patient, she's 73, she's diabetic, normal renal function, and again, chronic stable angina. And we did a CT, she has a very high calcium score, and I'm sure a lot of us here in a very elderly female with a high calcium score, and we know she's ischemic, are going to be very reluctant to do an angiogram. And we didn't do an angiogram. She had a low heart rate, she was an athlete actually. Her blood pressure was normal, it was not low, and she was given a higher dose of nitrates. She got a lot of headaches from the nitrates, even with the lowest dose, actually. And here again, with the statins, with the aspirin that we gave her ranolazine in the 375 milligrams, and she started to get better. So there is another indication, and this is what we just saw with Professor Tamer. What if the patient has a low blood pressure or a low heart rate? Beta blockers, which are extremely important in heart failure and in ischemic heart disease because they improve the myocardial oxygen consumption through the reduction of heart rate and so, cannot be given in all patients. And here, metabolic agents like ranolazine are very beneficial. This is another lady. She's not so elderly. She's 68. She's not hypertensive, I'm sorry, and her blood pressure is a little bit low. Her heart rate was regular, sinus rhythm, elevated, and we could not give her any beta blockers or calcium antagonists. Her functions were normal. So she was given, ivabradine. Her heart rate is improved. We started to up-titrate the ivabradine. She got flashes, so we went back to the 5 milligrams twice per day, okay? But she still has chest pain, so what to do? Definitely nitrates. Still has chest pain, okay, nicorandil. Severe headaches, remove the nicorandil. Again, these metabolic medications like ranolazine are very self-limiting when talking about adverse events, and chest pain did improve. Again, when you're talking about a low heart rate, a low blood pressure, whether the heart rate is high or not, we can use these metabolic medications like ranolazine very well. This is another patient with heart failure. Actually, it's an ischemic heart disease. He sustained an infarction. He's young, and he's doing very well on antihypertensive therapy, full dose beta blockers, sacubitril valsartan, and exercising. Started to complain of a little bit of chest pain. We did an angiogram, again, just like the first patient, small vessel disease, microvascular dysfunction. And can we give the medication? I went back to the literature. I was not sure. Can I give ranolazine for chest pain in a patient with heart failure? This was a question that I hadn't the answer at the time. And actually, I went back to the guidelines, whether it's the paper published by Manolis et al., it can be given, or even the heart failure guidelines of 2021, when we have a heart failure with reduced ejection fraction, preserved ejection fraction, and there is ongoing ischemia and chest pain that is ischemic in nature, yes, we can give ranolazine. It's a class 2, as you can see. Who sees a lot of people with chest pain and no significant epicardial vessel disease? Nobody? Dr. Hani, of course, is أكتر واحد بيشوف وهو أكتر واحد يعني هيقول لنا yes. There is a lot of patients, whether in the acute stage, the MINOCA, or in the chronic stage, INOCA, that we see patients with no significant epicardial vessel disease. It could be microvascular, it could be small vessel, it could be not anginal, but we have to make sure that it's anginal. And actually in this patient, before saying that it was not anginal, we had a SPECT, مسح ذري اتعمل, positive in the inferior wall. يعني it was a reversible perfusion defect which was evident. So definitely there is ischemia. What to do? One of the commonest medications that we give here was probably calcium antagonist. And we're going to discuss this in the next late-breaking trials on what's the data with calcium antagonists. Patient did a little bit better, still chest pain. What to do? Nitrates, she did a little bit better, but still not able to sustain her daily activities. She's old, she's 75, but she was very, very ambulant and working a lot. Then we added ranolazine, and again, if you look at how to assess microvascular angina and what can we give for microvascular angina, it's not just the calcium antagonist, not the vasodilator beta blockers, but also the metabolically active medications like ranolazine. So I'll just skip to that. This patient suffered a non-ST elevation MI. You can see the distal right coronary, there was a lesion. It was fixed, and she was doing a little bit better, but the recurrence of chest pain without any ST changes, without any enzymatic changes, without a positive stress test. And she did a dobutamine stress test. It was negative, but she's still complaining of chest pain. That is to say, there is probably ischemia, but not to the significance that she requires a new angiogram. And here with the, with the highest dose of beta blockers we gave her, she was still complaining. And actually, can we give her, after an acute coronary syndrome, ranolazine? And actually, yes, we can. Who sees patients with chronic obstructive airway disease? Comorbidities in Egypt? I think it's not so uncommon. And I think the first thing that comes to mind is a calcium antagonist. I agree. They're bronchodilators. They reduce the heart rate. They're contraindicated if you have a low ejection fraction, of course, because they reduce the myocardial contractility. But can we give ranolazine in such a case? Actually, this case, we up-titrated the calcium antagonist to the highest, a little bit of nitrates, but actually the nitrates didn't do anything. Side effects, And we substituted totally the nitrates with ranolazine, and the patient did well. And look at the chronic obstructive airway disease. It's not just the calcium antagonist. We can give cardioselective beta blockers. Let's be honest. We are overestimating the effect of cardioselective beta blockers on the bronchial tree. But definitely the metabolically active medications like ranolazine, in this patient, we up-titrated to the 500 milligrams twice per day, and he's doing great. Actually, this was not just a hypertensive patient. I have to say he was a smoker too. He's a heavy smoker, and this is why he had a peripheral vascular disease. And peripheral arterial, let's be more specific, arterial disease is not a contraindication. It's a relative contraindication. It's more like beware of your beta blockers because they might increase the symptoms. They might induce vasoconstriction. And here's the question, can we give the metabolically active medications to reduce the chest pain? Actually, in this case, his blood pressure dropped very much with the calcium antagonists. He was tachycardic, and here ivabradine, again, is a good medication to add when it's sinus rhythm. Of course, if it's atrial fibrillation, I would say digitalis is also another option. And we gave ranolazine from the start, actually, because his pressure dropped with the nitrates, his pressure dropped with the calcium antagonist, and actually, again, this is another indication by manolicitol. So, to sum up, I tried to recollect some of the patients I treated with ranolazine and take a look. Actually, we have a huge amount of patients that can benefit, not only because the medication has data to reduce outcomes or better symptomatology for the patient, but because the medication is one of the least side effects, one with the highest evidence, the only one with an indication in the United Kingdom and the United States. And the guidelines state this, whether in the chronic coronary syndrome or others, that these medications should be started off early on. So to take home, we've seen data presented by Professor Tamer on how these medications are important and how we should really be aggressive. Chronic coronary syndrome is a treatment with medication more than intervention. Sorry, Dr. Mohammed Zahran, great interventions, but let's also medicate the patients. And usually, maybe in 95% or 99%, we need more than one anti-anginal medication. Sometimes we are overlooking the comorbidities, the hemodynamics of our patient, but I think the medications that will be very easy to give, regardless, unless of course you have aggressive liver disease, ranolazine can really be put into this equation very easily. Thank you so much.
ثانك يو يا احمد. حد له اي كويشن او تعليق في الدكتور احمد بالنسبه للرنولازين؟
ميرسي خالص يا ابو حميد، حاجه جميله جدا. من فضلك هل في objective evidence، يعني مثلا زي سبكت زي ايكو زي انجيوجرافي يبين غير الانجين، يبين ان الرنولازين ليه يعني؟
I think this Dr. Tamer is please.
Dr. Ahmed, he is mostly for symptomatic patients. تمام. Chronic stable angina is patient stable with some complaints or some symptoms that will be well controlled with ranolazine. We haven't an advanced ischemia. We don't search for an evidence of ischemia. We are searching for relieving of the chest pain in stable patients.
Thank you.
To say it.
Very elegant presentations as usual. And I think one of the causes that the patient posed to intervention that they are not optimally treated by medical treatment. And that's why, because of some of the side effects of the medication which previously used like nitrates or nicorandil, as we all know, they have a lot of like something like headache side effects. The patient stopped it and started complaining from chest pain, and that's why they are pushed for coronary angiography. But if they are given such ranolazine without or minimal side effects, they were optimally treated by medical treatment, no chest pain, he or she will not never be pushed to the coronary angiography and intervention.
Great
To
comment.
say it again, there is no definite optimal treatment. We should use individual characteristics and preference to adapt the optimal medical treatment for every patient per se.
Exactly. And I take this from Professor Tamer and Professor Hani Raghi. I always remember his word on this part. Ranolazine is the only one with an indication by the FDA and the NICE guidelines. We don't have an indication to other medications by the NICE guidelines or the United States FDA. So this is one. Number two, it has a direct, like you said, Professor Tamer, a direct effect that we know of, not postulations or theories on how it works. And this really makes us more confident with the meds.
Thank you, Professor Ahmed. I think one of the major assumptions or the problems that the metabolic drugs has no solid ground as regard the mortality.
Of course.
Then we are reluctant to give these drugs.
Yeah.
But now, the era, the last decade, the quality of life has been upfronted in the trials like heart failure, etc. So we are justifying to have these drugs, especially when comparative, like in ischemia, like in courage, so we should go for maximum.
Agree totally. Thank you.
دكتور ياسر
Last
لو
comment
احنا
وليد.
كنا قلنا في الاول هل ممكن مع الوقت يصبح الرانولازين لعيانين الكرونيك اسكيميك او كرونيك سي سي اس نفس الايفكت بتاع الانترستو لما ابتدى يجيب الايفكت على الهارت فيلير؟ احنا كنا بنتكلم في الهارت فيلير اول حاجه طبعا بيند كان الكواليتي اوف لايف هي الموست اوبجكتيف في العين ساكوباتيريال بازاتان، وكان اتعمل الكويستشنير وابتدى السكور يتحسن. فهل ده يبقى تارجت اوبجكتيف كافي لينا ان احنا ناد اون الرانولازين في العيانين الكرونيك اسكيميك زي ما احنا بالظبط ابتدينا؟ ده بياند ان هو هيتحسن على مستوى الاجكشن فراكشن والهيموداينامكس والريموديلنج في العيانين هارت فيلير. اوكي. هل دلوقتي بالنسبه لنا هل انه الكواليتي اوف لايف از not enough target انك to proceed with any intervention او drug to go with or not؟ من داري. Yes. Yes. Even if impatient with CTOs. Even if impatient. Yes, okay.
I think ranolazine, Dr. Tamer,
وليد.
ranolazine, we can use it as add-on. It's not a routine. Looks like interest in heart failure.
Not a routine. Yes.
Yes.
No routine. No routine use
حضرتك
for
بتقول
drug.
ان احنا الرانولازين هنوصل بيه ان احنا we'll add
لا احنا بنوصل بيه انه في السيمتوم ريليف نوصل بيه بنفس الجريد او نفس الديجري اللي بناخدها في الكاتيجوري ثانيه. يعني بالنسبه لهم يعتبر از يعني هو بيعمل سيمتوم ريليف او ويل كنترول للكواليتي اوف لايف with no chest pain. هل يعتبر احسن الكواليتي اوف لايف في الكاتيجوري دي نفس الكاتيجوري الثاني اللي هو بتاع الهارت فيلير اللي اتحسن فيه برضه؟ يعني انا ما بقارنش الاثنين ببعض. بل هل يعتبر از يعني هل البين والشست يبقى فري من الشست بين ويعيش حياه وكواليتي لايف نورمال بالاد اون في الكاتيجوري بتاع السي سي اس يعتبر هنا التارجت؟
شوف سؤال وليد.
اوكي.
وليد اتفضل.
طب ثانك دكتور احمد، بس عشان سؤال شورت عشان دكتور اشرف بيشاور لي. If there is any reported side effects regarding the use of drug or any consideration should be taken in patients with renal or hepatic dysfunction?
Mainly in hepatic dysfunction, Child-Pugh's B and C, beware, no renal considerations of significance as per insert leaflet. But the side effects are placebo-like. And this goes to Professor Ahmed's discussion with Professor Tamer. Professor Tamer is not saying this is a medication for everybody. It is probably a better medication because it does not do enough as much side effects, as much as nitrates, nicorandil, and stuff. So a lot of medications are stopped, including statins, because of their side effects. Something like this not only improves outcomes, as we've seen by Professor Tamer, but it improves symptoms, and symptoms improve outcomes. And the third of all, no side effects.
Okay, thank you, Professor Tamer. Thank you, Professor Ahmed. Actually, the next session has a history, game-changing trials. I think as was discussed with Dr. Tamer now, that we are the conference that present around 30 trials in each year. Dr. Tamer working all the year to prepare for the game-changing trial in the cardio risk. But he have a difficult task. The presentation is 8 minutes, Tamer? 8 minutes. 8 minutes with 2-minute discussion. And just a few days ago, Tamer told me that in ACC, I think, or in another meetings, they present the trial without discussion. Because the objective is to give you what is this trial, what is the take-home message, what is the most important part of this trial that helped us. And if you want to discuss, I want you to refer to Dr. Hani Ragi post this morning on the Facebook on when to ask questions and how to control yourself if you want to ask us questions to save time. Okay, so I will leave the mic to Professor Tamer, Professor Ahmed Shawky, Atif Al-Bahri, Yasser Hussein to moderate and chair this session.